Okay, Dr. Deepak, is he there?
It was a wonderful talk, sir. We could see some cases which was like really tough to execute, and especially sometimes it develops non-union after even fixing it with plates and all. And usually in this part of the world, patients present like this. पापा बोलते हैं लोथ नहीं हो जाते तब तक पेशेंट नहीं आते, कोरिया पेशेंट्स होते हैं. Dr. Deepak Sampath sir is from Bangalore, and he's come all the way from. He's a lower limb reconstruction surgeon.
Good morning, all. At the outset, I'd like to thank the organizing committee, Dr. Ashish, for giving me the opportunity. Is it connected? Just a minute. It's not getting connected. Okay. Coming to the topic, take care for severe varus knee deformity. What should be the ideal approach? I am Dr. Deepak Sampath, orthopedic surgeon from Hosmat Hospital, Bangalore. So varus knee is a most common deformity, yet each knee is unique and different. Hence a specific assessment and planning is required to get a desirable correction. So what causes varus? It can be either intra-articular or extra-articular. Intra-articular causes include cartilage loss when the mechanical axis of the limb shifts from the midline to the medial aspect. There is a loss of cartilage, which in turn leads to bony erosions over a period of time and osteophyte formation both in the medial side and the posterior medial aspect. Over a long period, there can be lax lateral structures and medial tibial defects. Extra-articular causes, it can be either from tibia or from the femur, secondary to trauma, tumors, and infection. I'll just enumerate the approach, the steps. Preoperative planning includes patient examination, scanogram, and valgus stress X-ray. Inappropriate technique, like good surgical exposure, sequence of medial release and removal of osteophytes, soft tissue balance, getting a rectangular flexion and extension gaps, and management of bone defects. A good rehab is a must. So coming to the preoperative planning, a thorough clinical examination of the patient is important, starting from gait examination. Look for if there's any flexion deformity or a hyperextension deformity, or examine the hip and the spine as well. Getting a scanogram is important. So look for the HKA angle, hip knee angle, and the femoral valgus angle, and the MPTDA and the LDFA. So after that, a valgus stress X-ray should be done. Valgus stress X-ray to see if the deformity is correctable, partially correctable, or it is a fixed deformity. Correctable deformity, that means the release required is much less. And fixed deformity, the release required will be much more. This is an example of a valgus stress X-ray done where the deformity is completely corrected and the release required is much less, and you can reveal the medial condyle defects as well. So we can plan for the medial condyle defect as well. This is a valgus stress X-ray where there is a fixed deformity even on a valgus stress X-ray. So the requirement of a release is much more, and hence you have to keep a backup of constrained implants or semi-constrained implants in this case. So what's our principles of deformity correction? Is to achieve a soft tissue balance and to get a rectangular flexion and extension gaps, and to recreate the normal mechanical axis and reconstruction of the bony defects if there's any. So our release, how do we go up the release? This is first start with a good exposure, midline approach, and then we undermine the medial side and expose the quadriceps and the ligamentum patellae. Then a medial parapatellar arthrotomy is done. That's the workhorse for severe deformities. Once you do that, then we can release the fat pad and the anterior horn of the medial meniscus. The initial release is basically releasing the deep MCL and the osteophytes. So the deep MCL should be released as a sleeve of tissue from the bone, something like this, and undermine around 2 to 3 o'clock position. This is the initial release, and once this is done, we can remove the osteophytes from the tibia as well as from the femur. In spite of this, there are deformities, then we can release the posterior medial capsule, release semimembranosus in figure of 4 position. So our algorithm, so once we have released the first initial release of deep MCL and removal of osteophytes, after that, if the medial space is tight in flexion, then we release the anteromedial structures, and if it is an extension, then we release the posteromedial structures. In spite of this, then we do a medial reduction osteotomy of the tibia if it is tight in flexion, and posteromedial reduction in extension. If all these releases is not enough, then we do the superficial MCL release from the anteromedial aspect. That is, it has to be released from the anteromedial not more than 7 to 8 centimeters. And if it is still tight in extension, then we can do a pie crusting, where we do it in extension and use a number 11 blade and release the posterior part of the MCL. So this is the undersizing of the tibial component. So we can reduce the varus deformity by undersizing the component. It not only decompresses the posteromedial sleeve, but also helps in medializing the tibial tubercle and better tracking of the patella. So once we do this, we mark this area and then remove the extra bone either with a saw or an osteotome or nibbler. So coming to medial tibial defects, it can be classified either into small defects, medium defects, or a large defect. That is less than 5 mm, 5 to 10 mm, and more than 10 mm. So it can also be classified as central defects, peripheral defects, and composite defects. Central defects are a little more easier. You can use the bone grafts from the cuts and do an impaction bone graft, and that helps in filling the defect. The peripheral and composite, if it is a small defect which is less than 5 mm, we can use a cement mantle to fill it up. If it is around 5 to 10 mm, we can use cement with screws to fill the defect. If it is a medium to large defect, then bone grafts can be used from the cuts or from the allograft, and fashion the tibia according to the grafts and fix it with screws. In medium to large defects, there is use of wedges. The disadvantages of wedges is it is expensive, it is technically demanding, more amount of bone is has to be removed to put the wedges, and osteolysis can be a problem, and it does not restore bone stock for future revisions or anything. See, the advantage with the wedges, there is no need of bony incorporation or vascularization, and it avoids any collapse. Use of stem, especially in medial defects, so it not only adds constraint, but also offloads the metaphysis and transfers it to the diaphysis, and prevents toggling of the tibial components. The other indication for stems include osteoporosis, higher BMI, and these are a patient. This is a 72-year-old female patient with bilateral varus knee with subluxation of the tibia. And this is her walking gait with a mild flexion deformity and varus waddling gait. And this is a post-op X-ray where she had a medium-sized defect on the left side, where we have used screws with cement mantle and got a good correction. On the right side, she had a minimal bone loss, so we used only the cement mantle to cover it. So then another patient, 65-year-old varus knee, he had a medial stress fracture secondary to it. So we had to use a long stem below the stress fracture, which went on to heal well by 6 months of time. So the after surgery is important. A minute, sir. Early rehabilitation is important. You have to start on good rehabilitation early, active knee, range of movement, static quads, and full weight bearing. So my take-home message, you need to do a thorough preoperative planning, careful and gradual release of medial structures. PS design is considered superior to CR when especially dealing with a severe deformity. Plan for medial bone defects, keep a backup of wedge, bone grafts, and long stem and constraint processes should be kept as a backup when needed. And good rehab is important for good results. Thank you.
Thank you, Dr. Deepak. Very nice talk. We have question at the end of the session, so you please sit down. And next orator is Dr. Anupam Kumar. Are you here, Anupam? Yeah. He will talk on the navigation in the era of